thus enabling them to complete their treatment and live as productive members of the society thereafter. Sanjeevani predominantly works with underprivileged patients, and the program offered by them are totally free of cost. The core areas addressed by Sanjeevani are handholding, caring, counseling, emotional and financial rehabilitation of patients, and to create awareness on healthy lifestyle, prevention, and early detection of cancer. Sanjeevani started with just one caregiver, helping patients at Tata Memorial Hospital in the year 2012, and was able to handle over 500 patients that year. Current state inspired by Ruby ma'am's vision and commitment to the cause and the guidance of a vibrant board of advisors, Sanjeevani has had a phenomenal growth trajectory since inception. Sanjeevani currently operates in 12 Indian states, 15 super specialty hospitals, and has a core team of over 30 caregivers, 30 faculty, over 200 interns, and over 100 volunteers. We have enriched life of over 250,000 patients since 8 years of inception. Our flagship programs are Cancer Yogi, providing psychosocial support to cancer patients. The team, mostly cancer survivors themselves, currently help navigate patients through numerous fronts that open up during their journey with cancer and its treatment. Post COVID-19, handholding and counseling were made available over call too. Our next program is Satori. Satori is a wellness initiative focusing on holistic well-being of patients. The intervention is designed to improve physical and mental strength, thus improving their immunity and quality of life, and hopefully reducing the chances of reoccurrence of the disease. Post COVID-19, the program is also offered online. The next program is CanSarthi. CanSarthi is a skill development and rehabilitation program. So this 4-month certificate course in onco caregiving is targeted to train cancer survivors or those who are touched with cancer in family to become trained caregivers. Beside raising the bar of cancer care, this helps in opening up possible opportunities of employments for them. And our last program, that is Can Chetna, is an awareness initiative and advocacy with policymakers and communities to generate conversations around cancer. To know more about our organization, you can call us at our helpline number, that is 8691 000 800, 8691 000 801. Or also you can visit us at our official website, that is www.sanjeevanilifebeyondcancer.com. So now I would like to request Gausya to please play a small AV on Sanjeevani. Over to you, Gausya.
हमारे देश में आज की तारीख में हर साल 10 से 12 लाख कैंसर के पेशेंट लोगों को कैंसर डायग्नोज होता है.
You know, a doctor has about 4 minutes to talk to somebody, or maybe 3 minutes, or if you are in luck, then maybe 7 minutes or 10 minutes. But what can you gauge about an individual in 3 minutes or in 4 minutes?
I would see thousands of people going through a similar journey as mine without any of the resources that I had. I thought that I really need to do something which will bring this hope of life back into their lives.
कि मुझे इस तरह से किसी ने नहीं समझाया था.
सिर्फ इस प्रॉब्लम से बाहर निकलने के लिए नहीं, जो मुझे होल लाइफ मुझे सपोर्ट करेगा, वो कुछ उन्होंने मुझे दे दिया. थैंक यू सो मच संजीवनी.
देखभाल या जितना ख्याल यहाँ रखा जाता है शायद ही कहीं होगा. NGO बहुत हैं, बहुत बने हुए हैं, लेकिन ये जो संजीवनी जो NGO है, ये वास्तव में एक नया जीवन देने वाला है.
मेरे लिए तो सच्ची में बहुत रामबाण है, बिल्कुल संजीवनी की तरह मेरे को तो लग रहा है. बिल्कुल
Thank you so much, Gausia. Now, I would like to take the liberty to introduce our esteemed panelist.
Yes, Sumri ma'am. I guess you got some network issue, no problem. Yeah, please continue.
Yeah, so am I audible?
Yes, you are.
Yeah. So now I would like to take the liberty to introduce our esteemed panelist for today. So we have with us Dr. N Jayalatha ma'am. Dr. Jayalatha ma'am is director of the MNJ Institute of Oncology and Regional Cancer Center, Hyderabad. She is also professor of radiology and has presented papers in various state and national conferences. She has lent her expertise in the form of publications in national and international journals. Her focus has also been on conducting various cancer awareness drives, workshops, and screening programs. During last 3 years, she, along with her team, has conducted around 40 programs and screened around 35,000 people. We welcome you, ma'am, to this platform today. Next, we have with us Dr. C Ramachandra sir. So Dr. C Ramachandra sir is Director and Professor of Surgical Oncology, 𝙏𝙗𝙗 Memorial Institute of Oncology, Cancer Research and Training Center, Bangalore, with special interest in gastrointestinal oncology, breast cancer, laparoscopy, and robotic surgery. A doctor who keeps his patients' best interest in mind, also a recipient of various awards, and is a member of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, a flagship scheme of Government of India. We welcome you, sir. Next, we also have with us Dr. Umesh Mahantshetty sir. Dr. Umesh Mahantshetty sir is Director, Professor and Head of Department of Radiation Oncology at Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam. His expertise in the field of radiation oncology led him to reviews various national and international journals. He himself have innumerable number of international and national publications under his name. We welcome you, sir, to this platform. And also today we have with us Dr. Father Joseph. Father Joseph is a postgraduate in social work and secured PhD in social work on the topic village milk cooperatives in Kerala. He is currently the head of the social work department, Rajagiri College of Social Sciences, Kalamasari, Cochin. His major interest lies in developing partnership for civil society organizations and rural producer organizations with government as well as other resource systems in addressing issues related to sustainable development. We welcome you, sir, to this platform. And next, we have with us Dr. Kavya ma'am. Dr. Kavya Jyotsna ma'am is a social work professional, currently the head of the social work department of Dr. B.R. Ambedkar University, Srikakulam, Andhra Pradesh. She is an active advocate in the field of social work and has contributed to the society through various paper presentation in national as well as international seminars. As a result of her expertise in social sector, she has been invited to various conferences and seminars to deliver talks and chair sessions. We welcome you, ma'am. Also, with us, we have S C Sharada ma'am. S C Sharada ma'am is a company secretary and a law graduate with over 25 years of professional corporate experience. She is an alumni of IIM Bangalore, and in 2011, she was first women president of the IIMB Orators Club, a renowned Toastmasters club in Bangalore, and is an advanced communicator and advanced leader by the Toastmaster International USA. She believes in enabling and empowering her young team and takes pride in having groomed over several company secretaries We welcome you, ma'am, to this platform. And also we have with us Mrs. Ruby Ahluwalia, ma'am. So Ruby, ma'am, is a senior bureaucrat. She is an author. She is a painter. She is a TEDx speaker. She is a life coach. And most importantly, she is a cancer victor and the founder of the non-profit organization Sanjeevani Life Beyond Cancer, a pioneer in comprehensive cancer care. And also Ruby ma'am is the moderator for the program today. So now I would like to hand over to Ruby ma'am to carry forward the program. Over to you, Ruby ma'am.
Good evening, everyone, and a very, very warm welcome to the distinguished panelists here and the audience. I'm extremely grateful to each one of you to be here on this platform. And I hope that we are able to generate some meaningful conversation here, which will go a long way actually in the lives of so many youngsters who have joined with us on this meeting. I see that right now we have 426 people who are there with us. I hope we are able to generate some kind of a stir and we are able to create some change here. So just to lend some kind of context to what we are wanting to do here and why, let me share a bit of statistics with you. Breast cancer now has become the most common cancer in India, including the female and the male cancers. The other thing is that 50% of the cases in breast cancer are in the age group of 25 to 50 years of age for women. More than 70% of the cases are diagnosed in stages 3 and 4. And 1 in 28 women, as they estimate, 1 in 28 women may have to face cancer, breast cancer in their lifetime in India. In the urban sector, this is estimated to be 1 in 22. And in the rural sector, it is estimated to be 1 in 60. So this is how the situation looks right now. But I also believe that a lot can be done to change these estimates. Actually, we can. I'm very sure that we can do something that these estimates do not come true, and this is what the effort is also today. So I would like to start with Dr. Mahantshetty. You know, Dr. Shetty, as I was rattling the statistics here, what do you think has gone so wrong that the breast cancer cases are increasing by the day? And another thing which is happening is that in US, they say that a breast cancer patient has a 95% survival expectancy, although in India it is talked about to be less than 60%. So what would you like to comment on this scenario of breast cancer in India, please?
Thank you, Ms. Ruby, for this kind invitation, and I'm grateful to Sanjeevani for inviting me for this symposium. I'm so happy and glad to see so many participants, and I congratulate the foundation for coming up with such a fantastic symposium. And I would strongly urge to have such forums on a regular basis rather than once in few months. Coming to your question, yes, it is a sad story, not only in India, but also other developing and underdeveloped countries where the health infrastructure, unfortunately, is not really geared up. And that is one of the main reasons why patients with breast cancer do not present to us in early stage. Second important thing is, if you see underdeveloped countries or developed countries, which includes India, the literacy rate is far low in most of the states. And since the literacy rates are low, women who have some problem with the breast lesions or have some breast discharge, they never come to the doctor, they never go to the community health worker to find out what problem she has. And unfortunately, cancer is painless. So if there is no pain, they don't think that they should go to a doctor to review why he has some problems. And because of these reasons, they wait till the problem becomes really big. And that is why in rural India, even today, or for that matter, in many states across the country, we see a lot of breast cancer patients coming to us with a very, very advanced stage. And the most important factor for cure from cancer is the stage at diagnosis. So if we pick up stage at diagnosis very early, then it is curable to a large extent. And this is what happens in West or US. So they are very conscious. They go for screening. They go to a doctor regularly. They find out lesions which are very, very small. And when you pick up lesions, cancers which are small, then they are curable to the tune of almost 95 to 99%. Whereas in developing countries like India, if they come at a very advanced stage, then the cure rates fall down drastically by 50%.
Yeah, thank you, Dr. Shetty, for sharing this. And as it looks like that we need to have more awareness amongst women and men both about this cancer. Coming to you, Dr. Jayalatha, please let us know that these days a lot of women know quite a bit about their health of the skin, about the health of their hair, and they are very conscious of this. Do you think we are lacking somewhere in seeing breast as an organ where health is important? And what do women need to know in terms of symptoms if their breast health is getting compromised?
Yes, ma'am. Good evening, everyone. Really happy to see all of them on the desk, and happy to have such a symposium, which is very useful and need of the hour, as it is. As Sir said already, it is increasing on trend. And as you said, the numbers already, the 50% are falling between 25 to 50 years of age. And among them, 50% deaths are happening. So the most scary thing is the organ which is visible, which is approachable, which can be palpated and can be seen externally. It's an external organ. Even then, our numbers are too high. 18% of them are having in India, among all the cancers, it stands first, and the mortality is also first. As you know, 50 among 12 lakh cases, 11 lakhs or more than 7 to 8 lakhs are dying. I mean, deaths are happening. So this is all because the lack of awareness, the lack of identifying the initial signs and symptoms. Though we have all educated women with us, but it is some sort of stigma to come out and tell, and also some sort of some hidden fear that it might turn out to be a bigger lesion. And in especially the Telangana and some remote places, people are dependent on men to take them out to the cases for the investigations or for identification. And their most fear is the entire family will have to have a lack of their dailyhood, at least for a few days or something. And in developed cities, it is mainly because the habits, the poor, or the habits which are mainly the risk factors which they are not identifying, like their alcoholic habits, or the stressed out, or innumerable usage of hormonal pills or HTP or the other pills, and also the early marriages or delayed marriages or not having children. These are all known risk factors. And one more thing is they're not identifying their lack of approachability. Actually, there is no resources for them to tell that this is the place you need to go and regularly get checked up. And also the regular checkup. once in a while is not the need of the hour. You need to have regular checkups, at least once in 2 years or once in 1 year after certain age, after beyond 30 years. This awareness and early detection factors are lacking in our state. As sir already said, that in US or Western countries, it is mandatory for them to go after certain age yearly, unless they produce their health checkups. It is their counts are not added or their credits are not added. It's not the case over here in India. It is somebody whom the women are dependent on their family members or their men or somebody to take them to the checking points or the primary health centers or wherever. And one more thing is, we don't have enough system, the system which is falling in place, like where the primary care is taking place, where the confirmatory things are happening, where is the next level of the system is not falling in place. See, these are all the factors. Even, yes, last month also, we have seen all educated people coming up saying that their lump is already 2 centimeters or 1 centimeters, which is, as statistics says, all the case, more than 50% cases are coming in stage 3 and 4. Where we are not able to do anything after certain treatment protocols. But the same case, if they identify the disease in stage 1 and 2, 80% are curable, which is only 60% in India. So these are very sad state of affairs in our country, where women, the breast, which is an external organ, which can be identified, which can be detected with a simple and very early procedures, but still, because of the lack of awareness, lack of carelessness, or what do I say, that the young people are falling into these habitual things, and also their importance, not giving importance to the family life or career orientations, or lack of awareness, lack of knowledge, lack of priorities to get them to know the things which are involved. These are all the things which are falling into it and making the numbers very high and scary. And need of the hour is, we need to track, we need to develop a system where public and private are also involved. The people like you who are where the people get attracted to see the cancer care. So I won't say that, the people who come forward that, and then so here the citizens' role is important, doctors' role is important, at the same time the public role is also important, and women's health is as important as anything else. The entire family's support depends upon women's health. So we need to give them the health right from the childhood, educate them, these are the symptoms, this is how you have to approach, show them the protocol where you have to go, where is the next level of confirmatory happens, where is the next step to go. These are all the things should be taken care. That is what I think at the primary level now. These are the reasons why we are getting higher in numbers. Ours is a regional cancer center. Every day we get around, out of our 50 new cases, 28% will be breast cases, and the rest of the 25 will be cervix cases. And 5 and 10% are only the other cases which we are seeing, oral and health, or head and neck cancers. So rest of the 5% are the other cancers. This is how the scenario runs. And 18 to 28% is too high. Even Telangana is not an exemption. So even urban and rural areas, it is the same amount, with some amount of fluctuating in the percentages, but it is the same case. And educated people, surprisingly, educated people are getting affected, and they are also coming in delayed stages, stage 2B and 3A, 3. This is the main reason here is the lack of awareness and education. This is where we need to stress upon and develop this system.
Very well.
Thank you.
Very, very, very well said. Very well said. And I think Dr. Shetty as well as Dr. Jayalatha, both of them are meaning to say that people need to know more. People need to know more about their initial symptoms. People need to know more about what should be their right priorities actually. Dr. Ramachandra, I would like to ask you, like just now the discussion was happening that everybody has to come together if we really want to make a difference to this situation. So can you let us know what the government is doing in this regard to create more awareness or letting people know and making this initial healthcare more accessible to the public?
Well, good evening, Ruby Madam and Jayalatha Madam, Dr. Umesh Mahantshetty, and all the other faculties. Thank you for involving. Sanjeevani is doing a wonderful job. In this regard, if you ask me what the government is doing, I will say my sentence is not up to the mark. We have failed in that miserably in this country. I'm very sorry to say that compared to all other countries, India is still lagging behind in screening and creating awareness among the people. Well, as a regional cancer center in Kidwai, what we are doing is we conduct what is known as the cancer detection camps very now and then. In about 1 year and a half days, approximately we have done about 122 camps. We have 2 buses, and these buses will have a mammogram, X-ray, ultrasound, blood test, ECG, and a couch. These 2 buses will travel along with a team of people, and we'll go to the peripheral places, and wherever whoever requests, and our doctors and even the trainees will go there, staff nurses. And the buses are actually all around. It is covered with signages like a breast cancer tumor, a fungated tumor, and a mammogram mission, and a CT scan mission, and how a chemotherapy is being given. And all these things are all around. And the signs and symptoms of all other cancers, like a lump in the breast, be careful. Please report to the doctor, like that we mentioned. In addition to that, these are buses, we go there and we conduct camps, and we also take pap smear along with the examination. And the most important thing is whoever is suspected to have a lump in the breast after 40 years, we do a mammogram. And wherever required, less than 40 years, we do ultrasound. And wherever X-ray is required, blood test is required, we try to do a card to them. These patients are given a card so that they can come back to Kidwai Memorial Institute of Oncology. Once they come back here, and we'll give them priority and try to treat them, number one. Number two, the same line, the government of Karnataka has asked for the same buses like how we have done these buses. These buses, we have a branch in Gulbarga. There again, we have same kind of buses. And the government of Karnataka wants to introduce what is known as the pink buses. In that, they'll have a mammogram, ultrasound, and X-ray and blood test. This will go to the most remote part of the villages. I mean, especially the most rural part where they are not approachable for any treatment, like beyond the PHUs and the most innermost part of the rural areas. So there again, the buses again, we write all the signs, symptoms of cancer, like a fungated breast and tumor, like a buccal mucosa, all this, fungated buccal mucosa, why they come late. In spite of that, our country, the breast cancer is #1 in urban areas, and it is growing every day. Recently, I have done a surgery on a 19-year-old girl, a bilateral breast cancer. So it's very unfortunate, and it is the age of occurrence is decreasing day by day. And as of now, today, Bangalore is almost like 34 per lakh. So this is really alarming sign. In addition to that, we conduct every October month, we conduct a breast cancer awareness month. We do a series of seminars, like what is awareness created, what is the screening program, what has to be done. This we telecast it and call all the press people across all over Karnataka, and wherever possible, we try to create awareness among people. And we call some of the cancer survivors also during that time. We make them talk, and that will be recorded by the press people, and that will reach the common man, and why they have to come early. All these things, we try to create on this. Thank you.
Thank you, Dr. Ramachandra, and all the panelists. Please stay with us because we have more questions coming for you, so that we have a more wholesome kind of a conversation here. And Dr. Joseph, coming to you, you are heading the social work department of one of the most prestigious colleges in the country. And the students who come to study there, they are basically a very potent, they are very potent agents of social change. So what do you think could be the role of social work ecosystems in creating awareness on cancer.
Okay, thank you. Thank you for inviting. So, my dear fellow panelists and participants. So, I shall start from where the previous panelist, Dr. Ramachandra, has said. Government role is not up to the mark. There comes the space for social work students, civil society organizations in scaling up activities of awareness and developing practice. In social work, we often say knowledge, attitude, and practice. Creating knowledge, creating attitude, creating practice. I think this point of time, with the social media, with a lot of exposure, a lot of knowledge is happening. But as far as attitude is concerned, I think when you look at the breast cancer situation, it is more in the urban situation. Many educated women also contracting this disease, maybe lack of awareness and practice. So what we can do in creating awareness and practice, we need three types of activities. One is a continuous informal education through various media that is very much happening, including Sanjeevani's work, various NGOs. One NGO in Kerala, it is called Malabar Cancer Society. They have organized awareness program for 1.5 lakhs women in the northern region of Kerala. Similarly, we have a good network of women in the microfinance. You may be knowing the name is Kudumasri. They have organized continuous awareness program for women with the support of social work students, because in social work, we say field work. 2 days our students are in the field. They are working with either these microcredit groups of women or NGOs. Another powerful system is the ICDS, Integrated Child Development Scheme, where there is a Anganwadi teacher as well as the Anganwadi worker, and our students work with them. So they organize this program in partnership with the ICDS department. So continuous awareness is the way where students can participate, taking knowledge from doctors, district hospitals, village hospitals, continuous awareness program. Second is in social work, say if you want a change, we need collective action. Just creating awareness for 1.5 lakhs women, it is well appreciated, but the continuity is in doubt. So we need collective action where community-based organizations taking it up. In the panchayat, we have gender budgeting. So gender budgeting is part and parcel of the new Panchayat Raj policy, where 5%, 10% fund can be utilized for this kind of activities. Many a time it is not utilized. So if social work students ask the Panchayat through a RTA what you have done for the gender sensitization, especially of this awareness program for cancer and other things, similar engagement can be done by students. And the third is partnership with these organizations, government organizations like Kudumasri in Kerala. Similar organizations are there all over the country, and ICDS. So many a time our government officials are tied up with their administrative work. Even though they have goodwill to do the things, they don't have that human resource. So students can collaborate, not only social work students, National Service Scheme, NSS students, Students Union can take this to the forefront so that a collective action, and this collective action should result in creating local organizations, maybe organizations of women who will be continuously asking the doctor, conducting medical camps, breast examinations on a regular basis, and that kind of collectives, local collectives, not very big organizations that I am speaking, panchayat level, local organizations supported by a tri-party, maybe government, some NGOs with the funding, and institutions, especially colleges and so on. Right now, you may be aware that there's a program under Government of India, UBA, Unnat Bharat Abhiyan. Every higher education institution is expected to work at least in 5 panchayat, where they have to do awareness program, employment generations programs, skill development programs, and so on. So we are getting, if you take a college like us, we have more than 1,000, 2,000 students. So they would be working in these 5 panchayat if you calculate the man hours or human hours, a lot of awareness can be spread in the adopted villages. So when that happens at the macro level, I would say we'll be able to continuously conscientize using the word of proliferate. What we need is not awareness, conscientization. Conscientization means awareness resulting in action and behavioral change. So that is the need of the time where students community can proactively engage in communities under the platform. This UBA, Unnat Bharat Abhiyan is an official platform. There's a partnership between government, local self-government and the institution. So there's a credibility for students to go and engage in field activities. So due to this COVID time, that activities are very much limited. Otherwise, our students are physically present in the field for 2 days. In a week, a student is spending about 15 hours. So if you multiply with that all the students who are doing engagement in the field, and you take this as a focus initiative, definitely the resources in medical colleges, district hospitals and other NGOs, their resources with that knowledge resource, I'm speaking about the knowledge resource, can be utilized for creating continuous awareness for a change. So I conclude with 2 examples. If you take Kerala, Kerala was the first state who attained family planning objectives. The reason is it was a continuous talk. If you go to the cinema theater, if you go to the transport stand, there is pictures, there is announcement, we are 2, we have 2, or we are 1, we want only 1 child. So that we will be able to achieve. So continuous mission mode initiatives is required, where I would say the government of India have to come up with a program similar to such Bharat. So a mission mode initiatives only can create a sustainable change. Similar to the literacy program that you had achieved success in Kerala, because everywhere, I would say when I was a student too, all the students are in the field teaching student communities about alphabets and arithmetics. So 100 hours of work in the community, we got some credit at the same time the Kerala achieved under a similar trend continues. So mission mode initiatives are required at this point of time, where concerted effort by government as well as NGOs, and the focal point should be the local self-government. So we have a lot of freedom for the local self-government to initiate programs. So capacity building of local leadership can create wonderful changes for securing the health, creating breast health. That is all what I have to say, where the students can be a catalyst. Thank you.
Absolutely, absolutely. Very well said, Dr. Joseph. And Dr. Kavya, you are with us, and you are aware as far as the role of the non-profits is concerned in creating awareness. Sanjeevani Life Beyond Cancer in the past 2 months has conducted more than 250 camps and has reached out to more than 15,000 students. But I'm sure there is more that can be done. So I would like to hear from you, Dr. Kavya. Organizations like us, what do you think, what more can we do to make the young population of this country aware?
Good evening, Ruby ma'am, and all the panelists. And firstly, I would like to thank the organizers from Sanjeevani Life Beyond Cancer for giving me this opportunity to speak over this international symposium on breast cancer. Thank you very much. And I also appreciate that my video is not working right now. So kindly excuse me. I would speak over audio. So the first.
Please continue.
Yeah, the first thing is my earlier panelists have told that there is a lack of screening problem here, and there is a lack of knowledge, there is lack of information that should be disseminated to the public regarding breast cancer. So with this information, I would like to say that our role as educational institutions becomes more important than the in reaching the community, right? So for that, I would like to suggest that our organization is reaching, is in the rural, basically rural area, and we are reaching like more than 20,000 students right here in the north coastal Andhra Pradesh districts. So in this area, I would like to state that our university is a pioneer in UBA program, which is the flagship program for central government, and we have secured 3 projects right now from UBA, and one of the project is implemented in the area called 𝙏𝙗𝙗𝙗𝙗. This 𝙏𝙗𝙗𝙗𝙗 is very much popular for kidney patients. Like there are numerous incidences coming from 𝙏𝙗𝙗𝙗𝙗 area regarding kidney problems. So we have identified that area and we developed a mobile app so that the patients would report their problems through this app to the concerned doctors and all. So in this way, we are trying to reach the community, and we would like to spread this message that and connect the people from the both hospitals as well as the community. So in this regard, one UBA project is 𝙏𝙗𝙗𝙗𝙗 project. The other 2 are upliftment of artisans, and these 2 also we are doing. And right now, if I'd like to answer your question that what is our role in in this area of breast cancer, sorry if I'm what do you say, not fluent in this thing, please bear with me. We have students, and our students will be able to connect with people in the personal level, face-to-face level. Like we would go to door to door and answer and spread the message. Then secondly, we would organize surveys. Actually, our department is very good at organizing surveys, and the local government, district collector also has given us a few projects where the government itself could not intervene and collect data from the areas. So in those areas, we were able to intervene, and our students were able to collect data and give to the district collector. And also, we were able to support the district collectorate or the government mechanism by during the disaster time. Like we have faced many cyclones recently. Every year we had one cyclone. Based on these also, we were able to perform rescue operations, etc., like things like that. So in the area of breast cancer, we are very much new, and right now we are intervening into this area with the help of Sanjeevani Hospital, Sanjeevani Life Beyond Cancer. So with your partnership, we are trying to understand that and as well as go forward in reaching people, identifying the cases, early identification of cases, breast cancer cases, then treatment, counseling, these areas we would like to intervene.
That's great. That's great, Dr. Kavya, and thank you so much, for collaborating with us. And I hope that together we'll be able to do some wonderful work. And now we have someone with us, Sharada, who is a cancer survivor herself. And Sharada, you are as educated as one can be, actually, and you are a career woman, and both of us, we have so much of exposure in life. Despite that, we did diagnose our cancer pretty late. So when did you diagnose, in which stage were you, and what would have helped you to diagnose it earlier? Also, please let us know as to, in your journey, what worked and what did not.
Good evening, everyone. And thank you so much, Ruby, for this wonderful opportunity. I see 468 people logged in. This is an amazing opportunity, thanks to technology, and of course, thanks to you and Sanjeevani's initiative to bring people together. You're out there sitting in Mumbai, and you have got all of us in South India together, and we are able to reach almost the whole world, I think, through Facebook and technology. Thanks to that. Yes, like you have called yourself a cancer victor, I would like to definitely say we are cancer champions or cancer victors, because survivor gives a very negative connotation.
Yeah,
so
you are right.
we are leading a more fuller life. I would like to say cancer has been a life transforming experience for me, because it's life before cancer and life after cancer. That's how I would like to differentiate my life. As for your question about when did I diagnose, I was diagnosed with breast cancer in 2013. Like most women, I don't think I ever went for any mammogram or yearly checkup. Maybe the other kinds of general health checkup I did, but didn't focus on breast cancer as such, because I didn't have any family hereditary, though it was all there on my husband's side, but nothing in my mother's side. So I never thought I would get breast cancer. So actually, I must thank my maid, because it was my maid who came with breast cancer and told me about that. She started describing, and after that, suddenly it struck me that there is something wrong in me growing. I noticed a black patch, and then I realized that I may also have this. And I went to the doctor, because there was a symptom, but there was no pain, nothing. So that's when I went to the doctor, did series of tests. But thankfully, by God's grace, it was in the initial stage. It was in stage 1A, which is a very, very initial stage. But still I had to still go through all the process of chemo, surgery, and then radiation. So all the three were there. Maybe I didn't suffer as much as others. So that was when I was diagnosed with cancer. But I am happy to share with all of you that last 7 years has been a great journey, because I have rediscovered myself. I've learned a lot of lessons and takeaways from cancer and met some wonderful people. I've been getting an opportunity to work with some other support groups also to create awareness. By the way, I got treated in 𝙏𝙗𝙗. So 𝙏𝙗𝙗 is Dr. Vijay Kumar was the surgeon who did the surgery. I had access to some wonderful surgeons there. So that's what it is. I don't know whether I answered the other part of your question, Ruby.
Yeah, I just wanted to know, when you were going through your journey of cancer, what do you think, looking back, you could have changed, or you would have wanted some change in the way the society treated you, or the kind of treatment you got in the hospital or from the peer group? Would you like to say something regarding that?
Yeah, sure, Ruby. I think people like you and me are really the privileged lot. We come from cities like Bombay and Bangalore. We have access to medical facility, and thankfully, I also belong to a family which has a very lot of positive attitude all around. There was no stigma attached. First, the consulting firm, I made sure that I'm open about it. I did not wear a wig, because I said, it's okay if I don't have hair. My life is more important. Let me focus on the treatment part. I went around with a dupatta, perhaps, which was matching my dress. So what I did was, I wrote to all my clients and said, I am undergoing treatment. I may not be available for a few days or in a month, but I'm available, and I am very, very hopeful that I will come out of it positively. So first thing was, there was no stigma attached. And I did not find this kind of resistance from the society. But again, I'm telling you, we are the privileged lot. Not everybody is able to do that. I was open about this. And during the treatment, based on some of the suggestions I got, I looked at it as a milestone approach. For example, 6 lines of treatment, 6 times I have to go for chemo. Each one is with a gap of 21 days. It is a long treatment over a period of 9 to 10 months. Then it can become very worrisome, and you start becoming anxious. So I looked at it as, each time it was done, I said, this is done, and let me move on, let me move on. So those were the things of positive things which I started building in myself. And amazingly, I didn't realize that there is so much of internal power a person has. So I mean, even for a migraine, I would get worried and think, will I really get over this? But I don't know from where we got the power, internal power. I would also like to thank all the family and friends. Doctors in Kidney.
Yeah. So, what Sharada has said, trying to sum that up, and I was thinking, coming to you, Dr. Shetty, that Sharada was just talking about how the treatment for cancer is long, it is cumbersome, the side effects are there, which kind of at times I have, come across women who end up saying that we did discover a lump in our breast, but we decided not to go to the doctor because we feel that we will get into a cycle and we will not be able to come out of that. I meet a lot of such women. So, Dr. Shetty, would you enlighten us? Is there something happening in terms of research or in terms of work where the treatment protocol time can be reduced or the side effects can become a little more gentler? And this needs to go out to the public that cancer, number one, of course, is curable, and number two, that the treatment is manageable. There is nothing to get scared of this treatment. That needs to go out to the public. So, Dr. Shetty, would you like to tell us something in this regard, please?
Sure. Thank you very much for a nice, good question. And I'm sure out of 500 odd panelists who are there in the meeting, at least 60% are educated. And I'm sure you will agree that in past 2 decades, the science and technology has revolutionized whatever we are doing today. Classical example is you're doing a meeting with 500 people. 10 years back, if you had to do this, what an effort you would have taken to collect 500 people in one hall and do this symposium. So science and technology has really helped even the medical fraternity in terms of making the treatment better and better. For breast cancer, right from diagnosis to identifying very early lesions by imaging today, to the surgery where surgeons are now in a position to remove as less as possible the tumor along with the breast, so that the patient lands up with the breast tissue as original as possible. And they are also working towards reducing the extent of surgery in the armpit, because in the past, once the armpit surgery is done, a lot of women had this swelling in the limb subsequent to surgery. Now that is also being reduced because they are only picking up few nodes, few stations in the armpit, which can be identified and removed and find out whether the breast cancer has spread to those lymph nodes. And this is possible provided patients come with very early breast cancer. And by doing this, the side effects related to surgery are being reduced. Coming to the next treatment modality, radiation. Yes, radiation, when I was a student 25 years back, we used to give 5 weeks, 6 weeks treatment, followed by a gap, another week of radiation. So roughly around 2 months of stay, patient used to be fixed in Mumbai when radiation would be started. But now that radiation treatment protocol also has reduced. The treatment time, which is being tested now in Western countries, only 1 week radiation. So where 6 weeks of radiation and where 1 week. Having said that, even today, routinely, we are also reducing the treatment from 5 to 6 weeks to only 3 to 4 weeks now. And currently the research is going on 1 week radiation. And even in radiation side effects, the side effects we see 20 years back, we hardly see any side effects. In fact, women come, take treatment and go to office to work today.
True.
Which was not the case in the past. And plus, the technology which we are using in terms of giving radiation is also far, far better as compared to 10 years back. For third treatment modality, which is chemotherapy, I'm sure you all are looking at various websites. The treatment has been revolutionized in coming up with newer and newer drugs. The side effects have been tackled with newer and newer drugs to reduce the side effects in terms of vomiting. Classical example, simple example I can give is, we always tell breast cancer patients, oh, you are going to lose hair once we start chemotherapy. Now people are doing research and saying, earlier they said, no, we will get back your hair. But now people are saving the hair even during chemotherapy. As simple measure as that is available today.
Yeah.
And the other side effects, chemotherapy drug side effects are reducing more and more because the treatment, the medicines are more and more targeted only to cancer cells, and very less medicine goes to the normal tissues, and that itself reduces the toxicities. So all such things are available today to reduce the treatment time as much as possible. But having said that, I like some duration of treatment, because during that treatment, I'm sure you'll agree that the woman who is coming for treatment understands more about the breast cancer she has, interacts with other patients who are undergoing treatment, establishes contacts with them, shares the views and the problems she's facing. And by sharing, they come up with brilliant ideas. For example, a simple drain which comes from the armpit. It was a patient's innovation that they can put a Jola bag, and in that Jola bag, that drain pump.
Yeah.
That's an amazing innovation.
Yes.
So such things come out of these interactions. And last thing is, during this treatment, of course, the compliance is good, but after the treatment is completed, they become even bold. And living example is yourself. You have come up with an NGO. So imagine women like you, how many are there in the country who are doing such phenomenal work? So that itself helps to create a better society for women who are affected with cancer, and coming up with more and more opportunities for women to come up for treatment. Thank you.
Absolutely, absolutely. So very well said, so very well said. And I hope all the youngsters who are there and all the other people who are here have just now heard Dr. Shetty and heard that treatment is gradually becoming much, much easier and will only become better from here. So there is nothing to get scared. So it is important for people to know about the symptoms of breast cancer, yes. They also need to know that it is totally curable, and they also need to know that the treatment is very, very manageable. In fact, Dr. Shetty, you spoke about the importance of a kind of support group where people can come together and talk about their challenges and their issues. So in Sanjeevani, sorry, please.
One statement.
Yes.
Earlier, we used to always tell breast cancer patients that, treatment is for so much period, so much duration, you have to come for treatment. But today, you know what I tell them?
Yes.
You be happy that you have got an early breast cancer, because the treatment time period is limited. It may be running in months, doesn't matter. But this treatment is limited to only few months. Then you getting an hypertension and diabetes, for which you take treatment till you die.
Lifetime, yes. Lifetime. Yes, so, absolutely.
So I make them happy by saying this, that the treatment is limited for only few months. You are fortunate. There are 10 times more number of patients in the world who take treatment till they die, and that is for hypertension and diabetes.
Absolutely, absolutely, very well. And when we are creating support group virtually these days, so every day more than 200 patients log in with us and talk to us, and the kind of suggestions they come up with and the kind of interaction which happens is very, very beautiful and very productive. Coming to you, Dr. Jayalatha, I just wanted to ask you, what should people know in terms of the symptoms which are there for breast cancer, the initial symptoms, and what can people also do to reduce their chances of an occurrence of an incidence of breast cancer in their life.
Yeah, I think you're
because I'm getting a lot of messages privately and a lot of young people are asking these questions.
Can you hear me, ma'am?
Yes, please.
Yeah. You are rightly asked, the early symptoms of the breast cancer a woman would notice is a change in color is the one, and change in size of the breast, any internal puckering, that is indrawing of the skin is one more symptom, or any nodule which is palpable per hand when you palpate, or nipple retraction is another sign. Change in color, shape, size, and also the skin pattern is another sign. And any nodule, either in the inside quadrant, lower quadrant, upper quadrant, which is palpable, which may be painless. So you should notice painful or painless. Predominantly, they are painless nodules. That is where the people will start neglecting. And anything which can be palpable in armpit, in the axilla. See, you need not have a nodule in the breast, but you can right away have a part of the breast tissue is also there in the axilla, which is called axillary trail. So there also you can have a nodule. And sometimes with a small lesion within the breast, you will have lymph nodes in the axilla. So multiple nodules or multiple lymph nodes in the axilla. These are the signs. And also, especially if you pinch or squeeze, there may be a discharge from the nipple. Either it is watery or it is milkish, or it can have a blood tinge. So anything which is discharging from the nipple, when you squeeze it, change in the color, palpable nodule or visible nodule, or there's skin thickening at one particular area, or there is any altered color, like rightly said Sharada ma'am, or that there was a blackish discoloration of the skin which she noticed, and then when she palpated it was a nodule. So that is how it's going to present. A part of the breast skin or a part of it quadrant can be altered in color, and indrawing of the nipple, there may be some change in the nipple size, or there may be a indrawing. That means inside it is going inside the routine, this thing, especially the nipple or any part of the breast, and some pain, redness, dullness, and also dragging sensation. If there's a nodule in the breast, you feel like there is some heaviness or dragging sensation. These are all the signs and symptoms. So apart from this, if without externally appearing a nodule, there can be a deep-seated nodule which cannot show any signs and symptoms outside when you look at the breast. But there may be a subtle alteration in the change of the size, subtle alteration in the size which externally visible. And when you put a hand and see, you can feel a nodule to your palm or to the fingers with which you are palpating. So every time per month, as you get a monthly schedule, like monthly cycle, you need to palpate with your hand every month once in standing, once on lying down, to know whether any palpable nodules are there or palpable lumps are there within the breast. This is the most important one. And also, as I said, there can be a nodules in the axilla or a lumps in the axilla. So this is also one of the signs, or any color change, difference in color, difference in size, difference in pattern or integrity, or indrawing of the nipple and discharge from the nipple. These are the early signs which you have to alert and get examined, or early screening should be done. So the screening consists of mammography and ultrasound initially. So these will 80 to 90% will detect the nodules, and then further on you can go further, subject them for the confirmatory diagnostic test by doing biopsy. So all women after 30, there is a compulsory self-screening and a clinical breast examination by any doctor or a healthcare worker. Self is one of the things, and clinical examination by any of the doctor or healthcare worker. For that matter, ASHA or A&M trained people can have a look at the breast and can detect early signs and symptoms where further investigation should be done. So as Dr. Shetty said, that now the treatment aspect is very much modernized and you need not worry about it. Early detection is the key. Provided early detection happens, you pick up the lesions in stage 1 and stage 2, your cure. Cure is not away at all. It is just a step away from the detection and early detection. So I want to stress at this point, early detection is the key for the complete cure, and you will be normal as much as you smiling and giving the the glow to the entire world and saying that this can happen. So only key is, though it is standing first in the cancer list, but since it is being an external organ, key is detecting early and treating early. The detection pattern and the cancer treatment is very much modernized these days, as Sir said. And now we have patients who come regularly to us. In the morning, they ask us to fix the time for 10 to 15 minutes for radiation. They straight away go to their work. Even the high bureaucrats also, 1 or 2 people which we have, they come here, they schedule their time for the morning. They just spend 5 minutes and then they ask us to keep vacant and then fix that time and then straight away go to. Then it is not at all a problem. But signs and symptoms, detecting, early detection and concentrating on these is the key and need of the hour.
Absolutely, absolutely. Very well said, Dr. Jayalatha. Coming to you, Dr. Ramachandra, I wanted to ask if somebody notices any of these abnormalities in the breast. What are they supposed to do? Is there a protocol in place that, because see, most of the tumors or most of the discoloration or most of these symptoms would also be tumors which are non-cancerous. Yeah, so there is nothing to be kind of scared of or really press the emergency button. But yes, there are things which need to be done. So what is that protocol? If somebody notices this abnormality, what do they need to do? And just before Dr. Ramachandra takes this question, I want to let everybody know that apart from 470 participants who are there with us right now, we have also reached more than 4,000 people on the Facebook Live. So looks like we're doing a good job actually. So yes, Dr. Ramachandra, just coming to you please for that question.
It's a very nice question, in fact. See, basically, we need to, the moment the patient comes, we classify them into early breast cancer, locally advanced breast cancer, and the metastatic breast cancer. This is very much required basically because what modality of treatment we are going to offer to this particular patient. Before that, we will have to evaluate them completely. The most important thing is the FNAC. Suppose if it is early breast cancer, we'll do an FNAC. Or even locally advanced breast cancer, first thing in our institute, what we do is a fine needle aspiration cytology, a thin needle where it's not at all painful. Just put a needle, take a smear, and take on the thing, slide, and we'll tell within the same day, probably the next day morning, we'll give you the report depending on the workload here. No, that is number one. Number two, and we need to have a mammogram done. We need to see basically what is the architecture. Is it a single lesion? Are there any multiple lesions in this? And what is the architecture? Suppose if there is a satellite nodule, will it be operable for a breast conservation? Today, organ conservation is the order of the day. Wherever, whenever possible, any surgeon for that matter, we should conserve the breast. That is order of the day, I would say. And for that matter, this has come in everywhere, across head to toe in all cancers. Wherever, whenever possible, please conserve the organ. It's not like olden days where we remove everything and we do a mastectomy for all patients. So breast, we call it a lumpectomy axillary clearance, because otherwise we call it as breast conservative surgery. So this is the plan now. So in addition to that, we do a routine test like whether the patient is diabetic, hypertensive, or the liver functions, everything is okay, renal function is everything is okay. And we also do an ECG and a 2D echocardiogram. In addition to all this, we need to do a metastatic workup. So metastatic workup, by then the FNAC report would have come on the next day. Then we'll plan if this particular patient should undergo surgery. If it is stage 1 and stage 2, usually we offer surgery. And we call it as early breast cancer. Stage 3, we call it as locally advanced breast cancer, where the exact sequencing of treatment like chemotherapy first or surgery first is not defined. It is the surgeon's choice. If it is possible to operate, please operate. If it is not possible, give chemotherapy. By giving chemotherapy, the advantages are an inoperable disease can be made operable. Where surgery, where it is initially it was planned to be a mastectomy, we can convert into a lumpectomy. We can conserve the organ, and we'll also know the in vivo response of the chemotherapy. Suppose you give chemotherapy 2 or 3 cycles, the tumor is almost 90-95% is melted. You know that this chemotherapy is acted very well. That's called in vivo response. So after surgery, you continue the same chemotherapy. If there is a partial response, like about say 30%, 20% or 40%, you need to change the chemotherapy after surgery. That will help for planning the chemotherapy also. So this is about stage 3. Stage 4 breast cancer, most of the time we subject for chemotherapy. Stage 4 can be, the metastasis can be in the lung, liver, bones, or for that matter in the brain, anywhere it can be. Or even, many times, the diffuse nodes in the body, or, some metastasis elsewhere in the body, although we call it a stage 4 disease. This depends on the site of the metastasis. Suppose if it is only bone metastasis, they usually do very well. Whereas the visceral metastasis, liver and lung mets, generally they don't do well. Most of the time they are resistant tumors and they don't respond so well. So the prognosis comes down. If there's a brain metastasis, there we need to add radiotherapy also immediately so that they should not deteriorate, so that they'll maintain the quality of life. See that you stop the spread of the tumor in the brain. We add the radiotherapy at a very early stage. So this carries a poor prognosis again. So like that, this early breast cancer is 1 and 2. Locally advanced is stage 3. Metastatic disease is stage 4. We can classify that. Based on that, now, so if the PET scan is available across the country, we do a PET scan. PET scan will add more information to our knowledge, so that some of the disease is not seen with the naked eye, or for that matter, whatever we see, maybe probably it's much more will add. That will clearly tell us whether this patient has a clearly operable disease or an inoperable disease. If it is inoperable, then subject for chemotherapy. If it is operable, surgery first. Suppose PET scan is not there, you do a CT scan of the thorax and abdomen. So that gives more or less same information, but you'll have to do many investigations, then do a bone scan separately. So these are all the things we need to do. So bone scan need not do always. So suppose if it is early breast cancer, generally the chance of spread is less than 5% to bones. So maybe, we skip sometimes. So suppose if you are trying to do a bone scan, that will be a baseline scan. Suppose when you do a scan in the beginning itself, that will act as a baseline scan. Suppose in future, this patient comes with bone pain, something like that, you can always compare. Yes, in 2018, it was actually normal. In 2023, when the patient came back, there is a lesion now. So these are all the various advantages. So same thing applies for mammogram. The bilateral mammogram is not always mandatory. And if it is a conservative surgery, if you plan to conserve, definitely it is required. Suppose if you are not planning to have conservation, suppose a patient comes back with a second malignancy or a second malignancy in the opposite breast. After some time, you can always compare with this. This is called a baseline mammogram. Oh yes, that time it was not there, but now it is there, like that. So based on this, so there are different surgeries. So if conservation of surgery is being done, we do a lumpectomy separately and axillary clearance separately. And basically, once upon a time where the lymphedema, upper lymphedema used to be very, very high in incidence. And there are two important things. One is, we should not strip the fascia or the axillary vein. And second thing is, we should not go above the axillary vein. These are all some of the dictums to avoid the lymphedema of the upper limb or reduce the edema of the limb. So in addition to that, now what is known as lymphoscintigraphy. We inject a dye in the primary tumor in the breast, where the dye will travel all along into the armpit. It's called axilla. In the armpit, we do a gamma camera we put and see where the uptake is more. Compare with the primary tumor and this, if it is more or less similar, this is a sentinel node. Sentinel means it is a door polyp. That's the first node to be involved, supposed to be. You pick up those notes, along with that, pick up some more notes, send to frozen section. If it is negative, you don't have to go and complete the auxiliary clearance. And if you pick up about 8 notes in this area, or 6 notes for that matter in this area, when one note is positive all around, you can complete the auxiliary dissection. So you avoided the entire auxiliary clearance, you reduce the incidence of lymphedema. So in addition to that, primary tumor, always it should be separate incision. There is a clear-cut dictum that this kind of incision will give you a better result. So try to give a better result and try to put lot of positive things into the patient. That's very important. And never ever deprive them. And since we have started a psycho-oncology department, when Ruby Ahluwalia madam came to Kidwai, we did not have a psycho-oncology department. In fact, we mentioned last time. Now we have started a full-fledged psycho-oncology department, and everybody, and this kind of patient, generally we send them for counseling. They do a thorough counseling, and they put a lot of positive things into their mind, and bring them a lot of positive attitude, so that call the family members also. This is one more thing I observed in this is, especially when the people come from low socioeconomic status, some of the auto drivers specifically, what I have seen, generally most of the time they don't stay, they leave and get away. Educated people, generally they don't leave, they get a bond, they get attached to a woman. So this is what I noticed with educated and uneducated class. Uneducated class, usually, some of them for that matter, I've seen some of them, when they come for a 3rd or 4th visit, they come and cry, especially younger women, 35, 40 years. I ask, what happened? No, my husband is not coming for last 1 week. So these are all some of the things we are surprised to see. And this is very pathetic. We shout, you call them here. I call him, it's a curable disease. I'll explain to him. No, sir, he's not coming to home that 1 week. So these are the things we hear, strange things from the patient. And the next is, when we plan for surgery, we plan in such a way. Generally, we keep for a day. 1 day before and 1 day after only a surgery is the one. And if it is, some of the private places where we operate, same morning they come, if there are no comorbidities, and evening or next day morning they can go back home. It's like a daycare surgery, breast cancer surgery. It's very easy, simple, and most of the time they have to carry a drain, and we'll tell them to carry the drain for about 5-6 days or a week's time. And once the seroma comes down, we remove the drain. By then histopathology report is ready. Once the histopathology report ready, we send for ERPR and HAR2. If you are planning for chemotherapy, you should have done a true cut biopsy and ERPR, HAR2 in the beginning only. That is because sometimes when you give chemotherapy, there may be a complete disappearance of the tumor. Completely it melts down. So you don't have a viable or vital tissue to know your ERPR and HAR2. So you do in the beginning only. That doesn't apply when you do a surgery first. You always remove the tumor and tumor is in your hand. So based on the ERPR and HAR2 report, so we plan the chemotherapy. Like what Dr. Mahantshetty was saying, the time duration when we joined, the CMF was a regimen day 1, day 8, and every day 28. Like that, every month, 3 days a week, we used to give very toxic chemotherapy. And now AC is a 0, and day 21, and day 42, and day 63 is your chemotherapy is over. Not always AC is given, high dose AC. Sometimes we add with AC with Taxol, and sometimes we give, PAC, the 5-fluorouracil, adrimycin, and cyclophosphamide is one. Based on that, depends on the tumor biology. You see the ERPR status, and the entire thing we calculate, formulate, and we decide this chemotherapy will benefit this particular kind of patient. So these are the things, various things we take importance in this. And once surgery is over, we hand over to the either chemotherapy first or radiotherapy first. Whenever we do a conservative surgery, radiotherapy is mandatory. It is a dictum that radiotherapy should be given, because some of the trials is done in the past, including NSBP B06, the overall recurrence in the long run is more compared to when radiotherapy is not given. So radiotherapy should be given when a conservation is done.
Okay. Wow. Actually, when we are listening to this conversation and what all the doctors are saying, it's looking like that the treatment is becoming easier and easier, and this is what we need to know. Of course, we need to keep our immunity high, as Sanjeevani keeps talking all the time. We need to eat well, we need to breathe well, and we need to think well. And if we are able to crack these 3 things, that we have the right food, and we do the right kind of breathing, and we do think positively, I'm sure we keep our immunity high, and we are able to fight with anything that comes our way. But even then, if something happens, then treatment is manageable, it is easy. Please do not be scared. Every one of you who's listening here, who is a part of this seminar, please, when you go, talk to at least 20 people and tell them that cancer is curable. These are the initial symptoms. This is what you need to do when you kind of see an abnormality, and the treatment is very manageable. So don't be scared and keep your immunity high. So before we go forward, we have Professor Ramji here, who is the Vice Chancellor of Dr. Ambedkar University. He has shown interest in talking to us. So are you with us, Professor Ramji?
Yes.
It would be nice to hear you.
I'm there.
Ji, bataiye please.
Regarding
yes, please.
Once again, thank you very much for giving opportunity in the family of doctors. We are basically offering 2 courses in collaboration with GEMS. One is medical records and health information, and the second one is Master of Health Administration. One is the PG diploma course, another is the master's program. One innovative program what we are doing is is a backward area, as you know very well, Visakhapatnam district. Our students every Saturday, more than 70,000 students used to go to the villages throughout the district. They will do a lot of awareness camps, the one thing, and we have developed some proper ecosystem. Like there are 30 NGOs are there. All NGOs we are collaborating in that, like medical teams also there. We are going to the villages and we are conducting medical camps as well as awareness camps. Every Saturday it is a mandatory for students as well as faculty. Like that,
that's great.
Officials, state officials as well as NGOs and our students and faculty, we are forming teams. Whatever they are studying, that the objective is whatever they are studying, they use it to transform to the rural part of India. The second is the government schemes. They will try to educate, and in that team, one science and engineering and one medical these courses and one arts course. Students are forming a team and they are going to the villages and they are adapting the villages. See, that's why what I want to submit here in such an innovation program. If you need any awareness programs on behalf of your like breast cancer, because the villages, these are some of the problems they are facing. We will do those awareness programs. We will cover in the entire district of Srikakulam. If we are in the part of your organization body, whatever it may be, our Kavya madam will coordinate with your team. Definitely.
That would be great. That would be great, Professor Ramji. And in fact, we also train people to become professional cancer caregivers through a 4-month full-time training program. So if any of your medical social workers, actually, just to tell everybody, a lot of medical social workers are interning with us right now, and they are trying to understand as to what is the work that needs to be done in the whole cancer ecosystem. Since Sanjeevani works with all cancers, and Professor Ramji, we would be very happy to collaborate with you and take our work further.
We will be ready to do the job for any internship or anything. Thank you. Thank you very much.
Thank you so much. And now, Sharada, coming back to you, just let us know as to what kind of lifestyle changes you have made in your life after you have gone through an experience of cancer.
Yeah, Ruby, it's a very interesting and relevant question. When critical illness like this shakes you up completely, and it's a kind of crisis that you are facing, then obviously you'll start looking at life very differently. You'll live every moment, and because we have got a second chance, we want to make sure that we are living life fully. So the most important change which I made is, like you rightly said, you talked about eat right, breathe right, and think right. Think right, I started already doing it during the treatment, but breathing right, During the treatment itself, I started pranayama and yoga, which I am continuing. I feel breathing right is so important. It is the soul of life. Eating right. Last 18 months, I have changed the way I am eating. I have learned through a trained nutritionist what to eat, when to eat, what not to eat, how much to eat, when to fast, all these things. Basically, I am focusing on eating. My diet is more of a lot of fruits, vegetables, low on protein, and I'm completely out of dairy products, milk and dairy products. But this entire thing has made my system so strong. When you were talking about immunity, I think last 18 months I have not visited a doctor for cold, fever, cough, nothing. And I have been able to lead a better life. This is what I would like to say. And I think even during treatment, like some of the doctors were saying, you can take a treatment and go out and work. That's what I did. And I'm very happy to hear from both the doctors that the treatment time has come down and there are advancements in technology and treatment, which was not there earlier. So this was a change that I made of eating right.
Wow. Of eating right. Actually, so actually we should not wait for cancer to come our way to make these changes. And as you are aware, we do a 12-day immunity building program with the cancer patients and cancer survivors. And right now we are doing it virtually and it is free of cost. So if you know any cancer patient, please approach our helpline number and we would be happy to take them in our batches. This is a 12-day batch, which is a recurring batch, and it goes on like that. And people benefit so much from these programs that there is a total transformation which happens. So requesting everybody for that. Actually, now I think it would be better, since the questions are quite a few, that I would now hand it over to Sumki and Gausia to take the questions from the audience. Sumki, and please flag it with the panelists.
Yes, thank you so much, ma'am, and thank you to all the respected panelists. It's a privilege to have you all here in this platform today. So we have lots of questions like from most of the participants, and questions are very relatable. So now I would like to invite Gausia Parvin Siddiqui, our program executive, to please carry forward with the question answer session. Over to you, Gausia.
Thank you so much, Sumki ma'am. Thank you so much. So very insightful and beautiful session. We had discussion here, and because of that, we are getting lots of questions, and we have some raised hands I can see over here, and some questions in the chat box. I'll take few of them, ma'am, with your permission. Ma'am, first question we have from Nabarun. Nabarun, I would like to request you to please unmute yourself and ask your question, and let us know with whom you have the question.
Thank you, ma'am. Thank you so much, ma'am. So, I'm Nabarun Kakoti. So, my question is to Dr. Umesh Mahantshetty. So, my question is, what is the chance of recurrence of cancer in breast cancer patients? Is there any way that recurrence can be avoided?
Umesh, sir? Yes, sir. Please.
Yeah, so as I said, the key to diagnosis and cure is stage of cancer which is identified. So the recurrence chances are again depending on the stage. In stage 1, the recurrence rates are less than 5%. In stage 2, the recurrence increases to 10 to 15%. And in stage 3, another 10 to 15%. So 25% chance to 30% chance. In stage 4, the chance becomes even 50-60%. Now, second part of your question, how to identify them early so that it can be treated. For stage 1, stage 2, it is always good to follow the doctor's advice, wherein they would call the patient on regular basis to identify early recurrences. Early recurrences in stage 1, stage 2 are usually limited to the area where they have operated on, or to the armpit or the neck nodes. So this is only identified by the specialist who has treated the cancer, and regular follow-up, clinical follow-up is required for such patients. For more advanced stages, that is stage 3 and stage 4, The follow-up also will include doing an ultrasound of abdomen to find out whether the disease has come back in the liver. We usually ask for a chest X-ray if a patient has cough, and to rule out metastasis to the lung. And depending on, lastly, the patient's symptom, we also do some investigations directed to the symptoms. Let's say, for example, if patient says that I have been having a headache which is not responding to medications given by general physician, or she has some inability to walk straight, or there is epilepsy or convulsions, then we also do a CT brain or MRI brain to find out whether the disease has gone to the brain. So essentially, from breast cancer, there are 4 main areas where the disease would come back. One is lung, second is liver, third is bone, fourth is brain. So for bone, if the patient complains of bony pains, not vague bony pains which you and I have, bony pains which do not respond to the medications, and she is getting sleepless nights, and that pain is of new onset, then such patients we usually try to get an X-ray, CT scan, bone scan, as well as PET scan to find out whether the disease has come back. Strongly suggest all patients not to venture on your own looking at the internet and going for investigations. I would recommend you to go to the treating doctor who has treated you, and then find out whether investigations can be done to identify the recurrence.
Yes, sir. Thank you so much, sir. Thank you so much. Ma'am, we would like to move on to our next question. Next question we have from Namika ji. Namika ji, please unmute yourself. Yes.
Good evening, everyone. I'm Namika Maria, and thank you for giving an opportunity. So the panel discussion was very informative and engaging to us. But I have a question to Dr. Jayalatha, ma'am. Ma'am, my question is that, can breast cancer treatment affect future pregnancies in women?
Ma'am, you have to unmute yourself. Yes.
Yeah, am I audible now?
Yes, ma'am.
Yes.
Okay. Yeah. The treatment, that again, it depends upon the stage 1, stage 2, stage 3, stage 4, as doctors already explained. And if you complete your treatment, it is unlikely that it gets affected. First of all, the common age group is 25 to 50, and mostly after 40, after you finish your pregnancy or fertility period. Usually the cancer occurrence is after 30, 35 to 50 years. But in case if you have any family history, or in case any other nodule, as doctor already said that 20 years female was treated, in that case, if you complete your course and if you follow up your treatment, there is nothing that it can be affect your pregnancy in future.
Thank you so much, ma'am. Thank you so much. Next, we have Amala ji with us. Amala ji, please unmute yourself and please ask your question.
Okay. Hi, good evening, everyone. It was really great opportunity to be part of this session, and it was very informative. So I have a question. My question is to Dr. Ramachandra, DC Ramachandra. Sir, how effective is genetic testing in preventing breast cancer in people with a family history of cancer?
Yes, sir, please. Sir, unmute yourself. Yes, sir.
In fact, none of us have addressed this issue because, it's a smart session. We cannot talk everything what we know.
Yeah.
So it's nice if you ask. We do what is known as breast carcinoma antigen 1 and 2. So in this issue, the breast carcinoma 1 and 2, whenever we do, when it is positive, we call it a wild type positive. And, outside it might cost more. In Kidwai, we are charging about 8,500 rupees for this test. So this usually we do for people who have a strong family history, or anyone can come and get tested also. So whenever it is BRCA 1 and positive, the chance of cancer of the breast occurring in them is nearly 50%. Whereas when the same thing can apply to say cancer of the ovary also, they have about 35 to 70% chance of developing cancer of the ovary. Whereas when breast carcinoma antigen 2 is positive, the chances of developing breast cancer is about 35%. and ovary cancer is about almost like 10 to 30% of developing. But if you ask me, is there 100% foolproof that just because we do a breast carcinoma antigen study that we are very safe? Is not true. It is not 100% predictive. It is only a percentage. It can tell you that this particular test can be done. Number one, and when it is positive, it means you're categorized under a high risk category. So that will subject you for an intensive, the screening, like cell breast examination, and after 40 years the mammogram, and after 40 years every yearly once consultation of the oncologist. So what I suggest is, just because you do, it means it's not ruled out. Number one, by doing there is no harm. And these patients, when it is positive, they put them for intensive, the screening programs. And apart from that, there are a lot of genetic studies we do for treatment. I think it's endless, I think. Thank you.
Thank you so much, sir. I hope, Amala, you got your answers. Thank you so much, sir. We'd like to move forward. Next question, we have Sangeeta ji with us. Sangeeta ji, please unmute yourself and ask your question.
Good evening, everyone. I'm really glad that I attended today's session because I got to learn a lot of things. Thanks to all the panelists we have. I have one question for Dr. Joseph sir. Sir, like considering psychosocial counseling is very essential for cancer patients, can social work students be trained during their course of study to counsel patients suffering from any chronic illness such as cancer?
Okay, thank you for that question. As the syllabus of MSW program varies from university to university. In our college, we have, this is part of their curriculum, where they are sent to hospitals and they'll be working under trained clinical psychologist, where they are first in the college will provide the theoretical training, and they are in the hospitals. Some of our students were in Kidwai last year. So another RCA and so on. So it is all general, it's not specific to cancer, but more of a psychosocial training that is part of the MSW program. But we need to look at the curriculum at the national level. It varies from university to university and so on. So we are giving more focus to clinical social work, requesting the demand from students as far as placement, job opportunities, as well as social concerns are there. So next year, we are starting a new MSW program exclusively on clinical social work, where it is more of a practice-oriented, clinical-oriented social work, where intense training will be given to social work students who are interested to work in the clinical sector. Because social work is a more diverse opportunities and spectrums of activities, so everything cannot be taught in a 2-year program. So we are moving into a more specialized master's program in social work. So the first entry is next year we are moving to clinical social work. Similarly, into other sectors also more specialized PG programs. So where this kind of intense training is part and parcel of the teaching learning process.
Thank you so much, sir. Thank you so much. We have our next question from Malvika ji. Malvika ji, please unmute yourself. Yeah.
Okay, thank you.
Please.
The entire session was a really informative one. My question is to Sharada ma'am. Sharada ma'am has explained her own experience. So ma'am, you would also have the experience with the role of the caregivers. So do you have any suggestion to caregivers of cancer patients?
Yes, ma'am.
In what way? What is the suggestion you are in? From what perspective are you asking?
Ma'am, in terms of their attitude or like in the way they should behave or not behave.
Yeah. First thing I would like to say, cancer is not contagious. In the sense, you will not catch cancer like an infection, like some other viruses or disease. So you can live with the cancer patient. Only thing is the immunity of the cancer patient will be low So that is why, visitors should not come and visit us. But otherwise, the caregivers can always be close to us. But caregivers, I think, just like the patient herself or himself has to have a positive mindset. How does it come? You need a very positive atmosphere around you. So the caregivers also should think positively and keep saying that, yes, you will recover. The moment there is a negative thought, I think half the battle is lost. So it's very important that caregivers also feel positive about this. And I feel caregivers also, if there is a possibility, if the responsibility can be shared, then it is good to share. Because, for example, as a caregiver, we may not require any specific nursing as such, but what I've seen is the person cooking for you. You have to have fresh food. During the treatment, it's difficult for us to go and cook for ourselves, though we can do so many other activities, but fresh food has to be made. So many times juices has to be given, fresh food. So the person who is cooking needs some relief, and you need somebody to take you to the doctor. So generally the caregiver, if the responsibility is shared, I would say it is good. And he or she himself also has to be in a positive frame of mind. That helps. You keep the atmosphere light as far as possible.
Yes, thank you so
and
much.
And one more point I just want to make. One
Yes,
more point, like the doctors were saying, make sure that you trust the doctors. Once you have chosen the doctors, just trust them. You keep going and Googling and trying to read too many articles. I feel it's a wrong thing, because I didn't do that. And if you start comparing with so many other patients, somebody got some treatment, why didn't I get that? I think doctors know best. Leave it to them. They are like gods. They will take care of you. That's what I want to say.
yes, ma'am. Thank you so much, ma'am. Sir Ramachandra, sir, there is one question in our chat box saying that participant does not want to disclose her name. Sir, she's saying that I have a cyst in right breast and was measured 0.8 into 0.5 centimeter, and sometimes I feel pain also. Is it a symptom? Early symptom?
Well, what is the age of the patient?
Sir, that has been not disclosed by us.
No, most of the time, what is known as the normal evolution of the breast, we call it. See, as a woman, when they attain puberty, that is the time the breast will start developing. Slowly, over a period of time, it will develop completely. And usually they attain menopause around between 50 and 55 years of age. So as you grow older, woman, what is known as by nature evaluation, what happens is over a period of time, it becomes more fibrotic, more cyst formation will be there, and then more adenosis. It means it's more nodular. It's like what was there at the soft breast during, the initial period of the life in the younger age group. So over a period of time, it becomes lax. There is more fibrosis, more adenosis, more cyst formation. All cysts are not malignant, number one. Number two, a 0.8 centimeter cyst, most of the time it is only a single cyst. I don't think you have to bother. If it is really painful, put a needle and just aspirate and observe and see. Repeat an ultrasound, see, and whether it is refilling or not. If it is not refilling, that's all the treatment. If it is refilling again and again, then probably it calls for evaluation. Probably you'll have to do a mammogram that time, or completely see whether there's any changes, or is it part of the cyst is solid also. That you'll have to check, number one. A 0.8 centimeter cyst in a AL and healthy woman, you can just ignore, nothing to worry.
Yes. Yeah, thank you so much, sir. Let's move on to next questions. We have Pratik with us. Pratik, please unmute yourself. Yes. Please ask.
Hello, ma'am. My name is Pratik, and actually I'm from a small village called Gogamuk, and I wanted to ask a question to Kavya, ma'am. It is because people from my village, they exactly do not know what cancer and all these deadly diseases are. So according to you, ma'am, how can social workers make sure that the awareness regarding these diseases go to the underprivileged and underdeveloped sections of the society?
Okay. Actually, social work education is very much equipped in training students so that they can carry the message to the underprivileged sections of the community. Okay, so in that area, because the students have one advantage, like they will have the colloquial language where they can communicate with the society and spread this message to the people. and educate them about cancer, and identify whatever symptoms that the people tell them, and even they can guide those people to the correct areas where this medical treatment is available. So in that way, the students can in the rural areas or tribal areas can guide the especially tribal areas. Most of the time in the tribal areas, what happens is that uh, uh, the women, they try to cure the symptoms with the available local natural remedies. So because of that, they try to neglect whatever symptoms that they see, and most of the time they don't seek any doctoral services, because they need to travel a lot of long distances to reach a primary health center. So because of all these constraints, it is imperative that the social worker student can go to these unreachable areas and provide information regarding cancers. And if these people, if the students can educate tribal and rural people in their own colloquial languages, not using all the technical jargon and all that, but make them understand in their own language, then I think people will be more approachable, and they will be more accepting the concepts which we are stating, and awareness will be reached. So I think this is the best way of doing it.
Thank you so much, ma'am. I hope, Pratik, you got your answer. Jaya ma'am, we have question for you in our chat box. Yes. Ma'am, why do women experience a painful lump growth only during menstrual cycle? Is this something part of PMS?
Yes. Thank you so much. See, many, as sir already said, Vijay Kumar sir, it is the process of breast development, and in younger, invariably, when they are in younger age, when they are having menstrual cycle, because of their hormonal changes in the body, because of their estrogen and progesterone cycles which are going on, there is a premenstrual engorgement of the breast. That means the size of the breast will increase, the painfulness also increases, and subsequently, as they menstruate, as the cycle ends, the size of the breast decreases, and the congestion and the breast size also, and also the painfulness comes down. And part of this development, there is some cyst formation during, majority of them, 60 to 50% of these cysts are benign, nothing to worry about them. Even if they have some simple fluid collecting cysts, which we call them a benign cyst or adenosis cyst, they're all benign, nothing to worry. Only when there are alarming signs, as we said earlier, if they are present, then we need to approach the doctor or the facility, whichever is available near to us. So the size increasingness, the painfulness just before the cycle or during the cycle, when menstrual cycle is common. It's a natural process, or it's a natural phenomenon where your body undergoes a hormonal change, and your as the cycle comes down, as the menstrual cycle comes down, your symptoms and signs will also come down. That's a normal process, nothing to worry about it.
Thank you so much, ma'am. Thank you so much. We have last question for Shetty sir. Sir, there's a question from a young girl. She's saying, I'm 22 years old. My nipples are not in the same size. So I want to know, is this a symptom of breast cancer?
I don't think so. Nipple size per se is a sign for cancer. What is more important is if there is any lump, if there is any bloody discharge in the enlarged nipple, or if you are feeling a lump behind the nipple found out during your bathing or during your dressing up, then that is alarming sign for cancer. Having said that, don't diagnose yourself that this is cancer, so I'm not going to do anything about it. Please visit a doctor, find out why that breast lump, why the nipple is large, whether it is because of something which you felt behind the nipple or there is a discharge. Then investigations have to be done, as Dr. Ramachandra said. And once investigations say that there is a cancer, then the treatment has to be proceeded.
Yes, I hope your doubt has been resolved. Thank you so much, sir. Thank you so much. Thank you so much, all the panelists, for answering the questions of our participants. And now I request Suki ma'am to please join us. And yes, Sumki ma'am, please introduce us to the Satori program of ours.
Yes. So as we have already discussed about the flagship programs that we are running. So Satori is a wellness initiative where we used to give different therapies, different sessions to the cancer patient, because whenever we talk about cancer is only not limited to the treatment, because there is always a fear that what if it again happened to me. So to remove that fear and to follow in the process of wellness, we are providing a online wellness session. Actually, it is in the physical centers also. We have our physical centers in Mumbai, Ahmedabad, in Jaipur. But right now, as COVID-19 is going on, so we are doing it online every day from 11:15 to 1 p.m. So if you know any cancer patients who need our help, you can refer them to us. You can call us at our helpline number, that is 8691 000 800, 8691 000 801. So also there is a small AV on the Satori program. So I would like to request Gosia to please play the video.
Yes, ma'am, definitely. I will play that Satori film. And before that, we see the Satori film. I would like to, let's have some Gana Bajana, let's have some music. So we have with us Vidisha ji. Vidisha ji wanna sing a beautiful song for us. Vidisha ji, please unmute yourself and join us.
Gosia,
Haji ma'am.
Can I make a request, please? Yes. Can we do the Satori AV first, and then we get on to the entertainment bit for the young people? And I'm again and again repeating young people as if entertainment is not for older people. What was that? No. So the entertainment for everybody. Please stay on.
Yes, ma'am. So as आपका request राखो पर, let's have a AV for Satori first. Okay जी.
After the treatment is over, then the patient is suddenly left hanging actually, and this was the time when one needs to work on the patient.
ये जो संजीवनी जो एनजीओ है, ये वास्तव में एक नया जीवन देने वाला है।
वैसे मैं कीमो करवा के आती थी तो पड़ी रहती थी 7-7 दिन तक, उठना नहीं, मेरे को उल्टियां हो रही है, मेरे को वोमिट हो रही है। मगर जब से ये मैंने सेक्शन स्टार्ट किया, उस दिन भी आपने देखा होगा मैंने हॉस्पिटल से सेक्शन स्टार्ट किया, वो किया, अटेंड किया, तो मेरे को इतना अच्छा लग रहा है ना, ये आपका सेक्शन मेरे लिए तो सच्ची में बहुत रामबाण है। बिल्कुल
मैं जब खाती थी, जब मुझे दवा चढ़ता था, केमो लगता था, तो मुझे चिड़चिड़ापन होता था। तो फिर जब मुझे भैया बोलते थे खाने के लिए, खाना खा लो या फिर पानी पी लो, तो मैं उनको चिल्लाती थी और मैं बस सो जाती थी। फिर मैं सोती थी, मुझे गुस्सा आता था, तब मुझे संभवी मैम का याद आता था, अगर गुस्सा आए तो उसको कॉपी पेन लेके लिखो और फाड़ के फेंक दो।
मैंने लास्ट 1 मंथ में इतना कुछ सीखा है कि जितना मैं थैंक यू बोलूं उतना कम है, इसके लिए कोई वर्ड्स नहीं।
So yes, this was our Satori program. And before we go on to the entertainment thing, I really want to thank all the panelists for coming on this. We have already reached out to more than 6,000 people on the Facebook Live, and it is still going on. So I'm sure we will reach out to more people. And thank you so much for coming here, sharing your knowledge, sharing what is happening in the cancer ecosystem presently, because that gives a lot of comfort to people, and talking to you, coming from you, gives a lot of comfort to people. And that is why we have divided these seminars into 4. We are doing it for the South and the North, East and the West. so that people get to know their own directors, people get to know in their city which is the hospital that is there, and how compassionate and how helpful and how accessible these doctors are also. So thank you so much. Thank you so much.
Thank you so much, ma'am.